address, I invite our President, Dr. Joseph Patani, sir, for the welcome address. Sir.
Warm good evening to all of you. I won't take much time. All senior IAPNs and senior people like Dr. Sukumaran, Dr. Jayakumar, all others. Let me start immediately. I am happy that we are under the auspices of IAP Kerala as well, IAP Kottayam as well as IAP, KGMO. Of Kottayam is conducting an interesting, very interesting and useful talk on acute asthma management. We know that Krishna Mohan sir is coming and taking the class. He is a good speaker. He is the state president of the Respiratory Chapter, and his moderator is our most pleasing as well as dynamic Jayakumar sir. I should say always his mind. Even he has something in his mind. He does not have anything in his face. That is the most important thing. He is HOD pediatrics in IMS, and he has so many other credentials which I am not going to talk. And Bennett Salem, I hope he has come with this cycle. I have seen 2 weeks before he is riding from all the way from Trivandrum to Kottayam in cycle, and he's of course he is young, but I really appreciate. On behalf of IAP and KGM, I welcome Dr. Krishna Mohan, Dr. C. Jayakumar, and Dr. Bennett Salem. My appreciation and welcome goes to all other seniors, including C. Jayakumar and others who are present here. And welcome goes to our KGM members like Severity and President Tony Thomas having come over here and bless this function. They are actually participating, even though the crowd is less today because of the examinations and all. I think it will be a very wonderful program. And all Srija, Manu, as well as Sahala, we all are welcome. All the people, let please concentrate well in the subject because asthma is getting recently, but my observation is that asthma is abruptly increasing its complications. So, warm welcome to all of you. Let us go to the subject start. Thank you.
Okay. Next, I would like to invite Dr. Bennett Salem, sir. So he is IAP State Coordinator of our Action Plan Empowerment of General Practitioners. Sir holds the post of Consultant Pediatrics in Specialty Hospital, Vellagura, and recently, sir had accomplished a cycling expedition which was carried out from Trivandrum to Kozhikode, and he was part of Silent Wheel Cyclothon 2022, which was organized jointly by IMA, IAP, and AOI. IAP Kottayam salutes Bennett Salem, sir, for his achievement. Sir, I invite you for our felicitation.
Thank you, Preja. Actually, general practitioners empowerment, even though it is a dream project of our IAP state president, actually it's getting fulfilled because of our branches. I thank Patani sir and Dr. Preja because Kottayam has conducted most of the programs in as far as general practitioners empowerment. I thank all the seniors, Sumaran sir and Jayakumar sir, for organizing such a wonderful program, because the asthma management is very important, especially in peripheral settings, and it is more important as far as we, the health service people, are concerned. For that, Dr. Tony and Dr. Sabarinath has joined with us with IAP, and it is very important for us to learn, especially the problem is mainly in periphery. Thanking all the office bearers of IAP Kottayam and Dr. Krishna Mohan as a speaker and all the seniors for arranging this program, and thank you very much, and expecting a good program for today. Thank you.
Thank you, sir. Next, I would like to invite Dr. Tony Thomas, Secretary, KGMO Kottayam, and he is working in GH Kottayam, for felicitation. Tony, sir.
Respected President Dr. Joseph Patani, Secretary Dr. Preja, Treasurer Dr. Sahala, and the IAP State Coordinator Dr. Bennett Salem, T.U. Sumaran sir, Jayakumar sir, then Krishna sir, and all the respected dignitaries on and off the dais. it's even though it's not a pleasant climate outside, the topic that has been chosen for today's discussion is excellent, because most of the peripheral doctors, especially working in PHCs, CHCs, and taluk levels, are struggling with the acute management of asthma, especially in the pediatric category. Unlike the adults, it's very difficult, and almost all the doctors do have difficulties in treating and managing the children, and we do have some amount of fear in treating the children. When it comes to the children, we are very hesitant at times. Rather than treating at the peripheral level, we refer to the pediatrician. So this topic would be of immense help to all the KGMOA as well as the health service people, and I really appreciate the efforts taken by IAP Kottayam as well as the state coordinator in conducting the programs at regular intervals. I hope this is the 5th program that IAP has been conducting in the past a few months. So this is definitely a commendable achievement from the President, Secretary, and other office bearers of IAP Kottayam. So I congratulate them, and as well as we are always thankful to the IAP, because we have been incorporated into this program schedule of IAP, and we are extremely happy in joining with you, and we extend all the help for this, and we expect a wonderful session in the forthcoming few hours, and thank you.
Thank you, sir. Thanks a lot. Next, we are going to the CMA Direct. The moderator of our session is Dr. C. Jagma, sir, who had retired as professor from Kottayam ICH. Sir is now head of the Department Pediatrics, Amrita Institute of Medical Sciences, Kochi. He had been state president as well as NNF state president in the past, as well as national EB member 3 to 4 times. Sir had been secretary of National Allergy Chapter also. Over to you, sir. Sir.
Most respected president of IAP Kottayam, Dr. Joseph Banyani, sir, Secretary Dr. Preja, Dr. Bennett, the state coordinator,
Sir is in train, that's why
Professor
range
Dr.
is
Q.
quite...
Sumaran, sir, and I'm very happy that I am for today's talk, as you said, in pediatrics, especially. Is it breaking?
No, sir, now it's clear. Now it's clear.
Camera off here.
Sir, video off here.
Video off here.
Audio. Sir, train la sir.
Video off here, video off here.
Sir, video off here, sir. Mute and sir. Video off here, sir. Video. Audio. Oh, sure. Jayuma sir told his bandwidth is really low. As he's traveling from train, he had actually got an examination duty and he's coming back after that, and now he's again in train. Okay, fine. I will go to the direct session, and now the speaker of the day. Today, our speaker is Dr. Krishna Mohan R. He is a consultant pediatrics under Kerala Government Health Services at present in Taluk Hospital, Balusheri, Kozhikode. He is chairperson of State IAP Respiratory Chapter as well as editor of National Allergy Chapter. He was National EB member, Respiratory Chapter 2021, and he has been joint secretary of Kerala IAP, State IAP. He had received state level Best Doctor Award 2019 from KGMOA and has edited many textbooks on pediatric allergy and applied immunology. Over to you, sir.
Thank you, Dr. Preja. Most respected chairperson, Dr. Jayagumar sir, my most respected teacher, Sukumaran sir, president of IAP Kottayam, Patani sir, secretary, my dear friend Preja, most respected leaders of KGMOA Kottayam. I am also a KGMOA member, and dear members of IAP, my dear friend, my senior friend Bennett sir, is my very close friend, and Manu. So first and foremost, let me thank all of you for giving me this wonderful opportunity. So I share my screen. The screen is visible. The screen is visible. Or
Yes, yes. Slideshow.
Slideshow. Okay.
Okay, fine.
Full screen. Okay.
So I request others to please mute. So this will be a very small presentation. As Dr. Preja contacted me around 3-4 days back to make the presentation on acute asthma, basically meant for general practitioners. So I have tried to involve only those things which will be practically important for general practice. And I have not included anything for the advanced management of PASU management involved. So basically, as all of you would have seen asthma, I know every one of us have seen asthma, and we have been managing asthma for long. But this session is just about what are the present evidence-based guidelines based upon the GINA 2022 guidelines. Recently, GINA has released every May, along with this World Asthma Day, they release the latest guidelines. So this is basically based on GINA 2022 and also our Indian guideline, the asthma training module from IAP. So I will be talking this under two headings. What is the home management of acute asthma, as well as how will you manage in a hospital? And when coming to hospital, acute asthma has management under several levels. We have to manage it under, usually in our OP, in our clinic, that is the usual scenario. Sometimes we have to admit the patient and give treatment from the ward. And in some other cases, the child is sick, we have to admit in an ICU and give some advanced management. So I will be dealing this topic under these headings. So first, I will discuss one case. We have an 8-year-old Anand, who is a case of bronchial asthma, who is under regular follow-up. And one day he helped his mother in cleaning up dust in the house. And after some time, after 2-3 hours, he started coughing continuously. So as you know, as I have said, he is a case of bronchial asthma. And so the doctor has already given him a written asthma action plan. So that is the first point that I would like to make. That is the most important thing in home management is that every doctor who is seeing an asthma patient should give their patient a written asthma action plan. So what is an action plan of asthma? Written asthma action plan. So this is a model asthma action plan. This was the one which was given to our patient, Anand. So it includes the details of the patient, his name, his age, his sex, and the regular treatment, what he is on. As you can see, as of now, Anand is on 100 mics of budesonide, BD, and the second column is for what all things the mother or father has to watch out for. So you can see 4 points there. This is just a model. You can modify based upon our local language and all these things we can modify. So in this asthma action plan, the watch out signs which are given are increased cough, breathing difficulty, nighttime awakening, limitation of activity and all. So, and it is written, if these symptoms increase, you have told the parent to start salbutamol inhaler, 2 puffs as needed, and 1 actuation at a time. And also, if the symptoms increase after exercise, you can give 2 puffs of salbutamol 15 minutes prior to exercise. So this is a model asthma action plan. And another important part of an asthma action plan is the red box, which gives you details of what you are expected to do when you are seeing an emergency. So that simply means that the above symptoms like cough and breathing difficulty becomes more frequent and severe, what is expected to be done. So in this model thing, what is written is that give 4 to 6 puffs of salbutamol, 1 actuation at a time, and repeat it after 20 minutes, 2 times more. That is total 3 times of 4 to 6 puffs of salbutamol. And still, even at the end of 1 hour, if the child is not improving, you have written start him on oral prednisolone, a stat dose, and then call the doctor. So this is a model asthma action plan, and the home management of usual acute asthma is as per our ATM and basically based upon GINA, includes the most important drug here is a SABA, that is a salbutamol. So you are expected to give 4 to 6 actuations through MDA with spacer. And one important point is that I have written 6 actuations. So one mistake the parents make is that they will take the MDI, connect it to the spacer, do 6 actuations together, and then make the patient breathe. So that is not expected. What is advised is that you give only 1 actuation at a time, and you make the patient take the breath, and with a gap of 1 minute between each actuation. So what is the importance of these 6 actuations? Why are you telling that you have to take 6 actuations? So 6 actuations through an MDA with spacer is equivalent to 1 nebulization. So if you are in a hospital, if you are giving a nebulization, the giving 6 actuations from an MDA with spacer is same as giving a 1 nebulization. So this is the home management. What is advised is that you give 3 times 6 actuations with MDA with spacer at 20 minutes intervals. So 20, 20, 20, that comes to 1 hour. Even at the end of 1 hour, the child is not showing adequate response. Then you can start the first dose of oral steroid. That is what is called as rescue steroid. And then you can consult the doctor. So this is in short about the home management. So some practical points about the home management. Basically, because this session is meant for general practitioners, so at least some of you may not be aware of how to use an MDA with spacer. So some basic things. So this is an MDA with spacer. The spacer is a very, very important add-on device of an MDA, especially when you are using in a child. Even though we say that without a spacer, you can, after the age of 6 or 7 years, you can use the MDA directly. It is always better that even in adults, if you use a spacer, that is much better. So how will you give and use an MDA with spacer? You will take the MDI, that device, connect it to the spacer, and before connecting it to the spacer, you have to shake it. So this is a list of some common errors. I have kept the list of errors to make you aware of what not to do. So the first thing that you have to do is that take the MDA and shake it. So not shaking an MDA is one mistake. Then you attach it to the spacer and make the child close the mouth around the mouthpiece of the spacer. And before that, the patient should be asked to exhale. Before taking the breath, make the patient exhale. Then you can tell the patient to take a deep inhalation and breath hold. So in small kids, sometimes it may not be possible to have a good breath hold. So in such patients, we can just make them breathe through the spacer. So that is using their tidal breathing. So, so these are some of the common errors. So as I said, you can use an MDA with spacer in two ways. One is taking a deep breath and holding breath for 5 to 10 seconds. So in small kids, it may not be possible. So actually, breath holding is a very, very important step of using an MDA with spacer. That is the much preferred technique. But if in any case that is not possible, what you can do is that breathe in and out at the normal tidal volume for 5 to 6 breaths. So if you are doing this, both these techniques can be used, provided you are doing it in the right way. Both these techniques have got the similar results. So coming back to our patient, this patient has followed our written asthma action plan, but the patient has not improved. So what happened? As what is written in the action plan, the patient consulted a doctor. So now the patient has reached your OP or your clinic. So the first and foremost thing that you are expected to do in such a scenario is that you assess the severity. So assessing severity is not only clinical, you also have to take a proper history. So history is very, very important. So what are the important points in history? So first and most important point is that you have to make sure that it is asthma. Sometimes a child presenting with an acute breathing difficulty may not be asthma. It can be a more severe condition like a foreign body aspiration. It can be some other cause which is causing an acute breathing difficulty. So make sure that it is an asthma. So how will you make sure? And one is age. Lesser the age of the child, more is the chance for an alternative diagnosis. Second thing is the typical history of asthma. Nocturnal worsening, recurrent episodes and relapses, then improvement with using steroids and bronchodilators, triggers, presence of triggers like dust, activity, emotions, etc. All these things are points favoring asthma. So in the history, the first and foremost important point is that make sure that it is asthma. Then the patient has presented before you. Then you have to ask, how was the onset like? Was it sudden? So usually what happens is that, as in our case, the patient has helped his mother in cleaning the house, and after around 4 or 5 hours, the child started getting symptoms. So that is the usual scenario. So if it is sudden, that means at 10 a.m. the child did something, and after 5 minutes the patient started getting breathing difficulty. That means you have to think of some other differential diagnosis. And the treatment history is also important. Was the patient on regular controllers, or was the patient not taking the drugs? Has the patient already taken any relievers? What was the response to that? Is there any trigger? All these things are important. Previous flare-ups is important, and especially the severity of the previous flare-up. For example, if the patient had a history of a very serious asthma attack, and if there is a history of mechanical ventilation or intubation for ventilation, that is a very, very important risk factor. So that in such cases, we have to manage asthma more. we have to think in a mind that it can cause more complications and have to act fast. So that is about history in assessing the severity of asthma. Now, how to clinically grade an acute flare-up? So in this case, on examination, what we are seeing is that this child is having a respiratory rate of 28 per minute with accessory muscle use. She is comfortable and able to talk in sentences. And on auscultation, there is a wheeze, but it is heard only at the end of expiration. Her SpO2 is 96%. So these are her vital signs. Now, there is another entity called as Pulmonary Index score. So this is one thing which all of you can use in your clinical practice. Pulmonary index score to grade the severity of asthma. You need not have to by heart this. You can take a printout of this and just keep it in your OP or your emergency room. And whenever the patient is coming, you can grade based upon this. So pulmonary index score is an index which was developed and validated from 2002 onwards, and it is a very efficient scoring system, and it has got only three criteria. Three entities are only there: the respiratory rate, the type of wheezing, and whether the accessory muscles are used or not. So respiratory rate, based upon the age, it differs. Then wheezing, the type of wheezing, is it terminal only, or is it heard throughout the expiration, or is it heard throughout the respiratory cycle? So, and the third entity is usage of accessory muscles. So the accessory muscles of respiration, includes the sternocleidomastoid, the serratus muscles, pectoralis major, all these muscles it includes. So how far it is used, based upon that, individual scores are given for each of these, and then a composite score is taken. And if the final score of adding all these three, if it is less than 3, then we say that it is a acute flare-up of mild severity. If it is between 4 to 6, it is moderate severity. And if it is more than 6, we say it is a severe case of acute flare-up. So this scoring system is extremely important. Even though it looks very simple, it is very, very efficient. So we can try this in our case. In our case, in which the patient came and her respiratory rate was between 21 to 35, and her wheeze was only heard at the end of expiration, so it is terminal, and the accessory muscle usage was questionable. So for all these three entities, the score is 1. So 1 plus 1 plus 1, it comes to 3. So from 0 to 3, the score is a mild acute flare. So this is how you use a pulmonary score system. Now coming to how you will manage a mild flare-up. Here the pulmonary score is 3 and it is a mild flare-up. So a mild flare-up who has reached your clinic or your OP, what you are advised to, you are expected to give is that you can give inhaled salbutamol or a short-acting beta agonist. SABA means a short-acting beta agonist. You can give 4 to 10 puffs every 20 minutes for the first hour. And you can continue the salbutamol inhaler 4 to 10 puffs every 3 to 4 hours till symptoms subside. Then the frequency can be reduced. And as the child was not improving at the end of 1 hour, from home itself, the child has been started on oral prednisolone. You can continue the oral prednisolone for 3 to 5 days. So another important point, if the child is already on an inhaled corticosteroid like budesonide, now what you are expected to do is that you can increase the dose of inhaled corticosteroid. You can just double it and maintain it for 2 weeks to 4 weeks. So in this case, what was done is that 100 microgram was the dose which was advised. It has been upgraded to 200 microgram. He was asked to follow up after 4 days, and after 4 days, he was doing well on this treatment. So that is how you will manage a mild flare-up in your clinic. Now coming to the second case. So this case is Smita, a 9-year-old girl who is on irregular treatment for asthma, and she was brought to the casualty with breathing difficulty. On examination, her respiratory rate is 40 per minute. A 9-year-old girl having a respiratory rate of 40 per minute. There were suprasternal recessions, and on auscultation, a wheeze was heard throughout the expiration. So, applying our pulmonary score system, how severe is she and how will you manage her? So, coming back to the pulmonary score, what was the respiratory rate here? respiratory rate was 40. So it comes between 36 to 50. The score is 2. For wheezing, it was heard throughout the expiration. So this expiratory score comes to 2. And there was an apparent usage of accessory muscle. That too, the score is 2. So adding 2 plus 2 plus 2, you get 6. So the severity of this attack is moderate. That the score is 6 and this is moderate. So how will you manage a moderate severity of acute asthma in the emergency room? So there also, the first drug that you are supposed to use is the short-acting beta agonist, salbutamol or levosalbutamol. So which is better? This is also a controversial topic. Somebody says levosalbutamol is not having any side effects, it is much better. It is nothing like that. In efficiency ways also and adverse effects thing also, salbutamol and levosalbutamol are almost equal. The only thing is that when we are strictly looking for the tachycardia, levosalbutamol has comparatively less tachycardia compared to salbutamol. But for all other practical purposes, salbutamol and levosalbutamol are almost the same. So SABA is the first drug, and you have to do a SpO2. And if the pulse oximetry, if you have done and the SpO2 is more than 92%, that means the child is not that sick. He will be able to use the MDA with spacer. Then in the ER also, you make the patient use the MDA with spacer 4 to 10 puffs every 20 minutes for 1 hour. And just like what we did at home, only 1 puff at a time, 1 minute interval between 2 puffs. But if the SpO2 is less than 92%, then it is always better to use a nebulizer. So this is a very, very important practical point. So what happens usually is that in home also, some doctors advise to use nebulizers. In hospital also, when they come, even if it is a mild flare-up or moderate flare-up, you directly start the patient on nebulizer. So that is not required actually. You can simply manage the patient using an MDA with spacer. There are ample number of studies to prove that in mild to moderate cases of acute asthma, a MDA with spacer is as efficient or sometimes more efficient than using a nebulizer. In this case, the SpO2 is decreased, is less than 92%, then you can start using a nebulizer. So always use a nebulizer with oxygen-driven nebulization. The frequency is just like when you are using an MDA with spacer, 3 times nebulization at 20 minutes interval. And if you have not started a steroid yet, you just start a steroid, can be oral or IV. Let it be IV or oral, the efficiency is almost the same. Only when the child is not able to take the drug orally, you are expected to give it IV. And continue the assessment for 4 to 6 hours. And assessment should be used upon the pulmonary score. And if there is a good response, if the pulmonary score is less than 3, you decrease the nebulization to 3 to 4 hours. So this is the management of moderate severity of asthma in the ER room. This is the dose of salbutamol, 0.15 mg per kg per dose. And for remembering for simple things, you can remember for less than 5 years is 0.5 ml or 2.5 mg of the salbutamol nebulizer solution. And in more than 5 years is 1 ml or 5 milligram of the respiratory solution of salbutamol. And the respiratory solution, it is coming in a strength of 5 milligram per ml, and Resputes it is coming in a strength of 2.5 milligram in 2.5 ml. You have to remember, Resputes are pre-diluted with normal saline, so there is no need to dilute it again. You can directly use the Resputes as such. So if you are using a nebulizer respiratory solution, then you have to dilute it using normal saline. So this is the dose. Now what? This patient has been given salbutamol nebulization, oxygen was given, and the systemic steroids were started. Still, the patient is not improving. 1 hour later, her respiratory rate has increased. It has become 48 per minute. Now it is the time to admit her to the ward. And after admitting to the ward, that means now we have used 3 drugs. What are they? We have used salbutamol, oxygen, and systemic steroid. But still the patient has not improved. Now you have admitted the patient in ward. Then how will you proceed? You can start oxygen if not started yet. Start IV fluids, and if the child is unable to take oral steroid, you can switch to IV steroid and continue with the short-acting beta-agonist nebulization. And the next drug which we can try here is that along with this salbutamol nebulization, you add ipratropium. Ipratropium you can add, and just like giving this salbutamol, you can give it 3 times at 20 minutes interval. You can either mix it together with salbutamol or alternate with this salbutamol. Both are advised. And monitor vital signs, the pulse oximetry, and in every 15 to 30 minutes, you do reassess the pulmonary score also. And what about the investigations like CBC, chest X-ray, potassium, etc.? So these tests, these are not routinely indicated. Only if you are suspecting any complications, in those specific cases, you can go for these investigations. So this is a dose of ipratropium. Ipratropium, you can start along with this short-acting beta-agonist, and the dosage is 0.5 ml in less than 1 year and 1 ml in more than 1 year. Every 20 minutes for 3 doses. So now we have used 4 drugs. We have started him on SABA, oxygen, steroid, and added ipratropium. So if the child is improving on this therapy, means the pulmonary score has come down, even then we have to continue the observation for at least 6 to 8 hours. But what if the patient worsens? If the patient worsens on this therapy, now we have to intensify the treatment. But before intensifying the treatment, you have to check that the patient has been given all the advanced treatment properly, and the oxygen has been given properly, the oxygen flow rate, all those things we have to make sure. Now, after giving these 4 drugs, now what are the options we have in our armamentarium? The next step, the patient is not improving. The other options that we have 3 more options. One is IV magnesium sulfate. Second is IV terbutaline. And third is IV aminophylline. Among these, the most commonly used and the one which is having a good quality of evidence is IV magnesium sulfate. Both GINA as well as the Indian guidelines are advising magnesium sulfate IV. So magnesium sulfate is a very wonderful drug. It acts through a different pathway, the calcium channel blocker. It has got an immediate bronchodilator. Immediate means it acts very fast. In around 2 to 3 minutes, it starts its bronchodilatory action and the mild anti-inflammatory effects. And its duration of action is around 2 hours. The dose is 25 to 50 mg per kg, or in ml, if you are saying 0.1 ml per kg, it is given as a slow infusion over 20 to 60 minutes, dissolved in 50 ml of saline. So this is how you are expected to give magnesium sulfate. And the adverse effects you have to remember, though very rare, hypotension if it is said, but is not usual. As you already have an IV line, you can start an IV fluid if you expect a hypotension. Tachycardia or bradycardia, these things muscle weakness at a high serum level, that is also unusual. Not it usually doesn't occur with a single dose. And Gina is advising only one dose of magnesium sulfate. It is not advising to repeat. So that is about max sulfate. And the other options which we have, one is IV terbutaline. It is not freely available. And the third drug which is an option is aminophylline. You will be remembering during our PG days, aminophylline was very commonly used. But as of now, Gina is not recommending aminophylline in the management of acute asthma, considering the very narrow therapeutic index and all. So as of now, the drug which is advised as a next option is IV magnesium sulfate. So we have used 5 drugs now. We started him on inhaled SABA, oxygen, systemic steroid, ipratropium, and magnesium sulfate. So about all the cases of acute asthma coming to our setup, 99.9% will respond to this much of management and this patient will become better. Only if the patient is not improving, we have to consider transarterial PAC facility. That is very, very rare. And at this stage, you can also consider doing a blood gas studies, but many a times in our peripheral setup, it may not be possible. So the patient has been started on magnesium sulfate. 36 hours later, Smita is showing signs of improvement. She slept well throughout the night. She is taking food, and on examination, her respiratory rate has come down. I hope you remember her respiratory rate was 46 per minute. Now it has become 24 per minute. And on auscultation, this is there only the end of respiration. So patient has improved. Another important question is, when and how will you plan to discharge her? This is very, very important. So you have to step down from the acute care. Like in any other condition, follow the principle, last in, first out. So if you have started or used terbutaline or aminophylline drip, you will first discontinue that. Discontinue ipratropium nebulization in 24 hours. Reduce the dose of SABA by decreasing the frequency of use. You can decrease it to 2 to 4 hourly and then 4 to 6 hourly. And if you have started an IV steroid, replace it with oral steroid. This is another important thing. What are the criteria when you decide to discharge a patient who has been admitted with acute asthma? So these are the criteria which has been mentioned in the asthma training module and the ABC consists of asthma. You can think of discharging the patient when the patient has improved. Generally, on general appearance, when the patient has improved, she is sleeping well, she is taking food normally, she is looking comfortable, and her pulmonary score is less than 3. And also, provided she is not on any continuous infusions and she is receiving less frequent SABA. And if the patient is satisfying all these things, then you can send the patient with a written asthma action plan. So this is another important step. When you are discharging, you have decided to discharge, what all advices you give on discharge. So you have to advise the patient to continue with the inhaled SABA using an MDA with spacer till the symptoms abate. This is a very, very important thing. Once the patient is discharged, please do not forget to tell the patient that she should continue it till her symptoms abate. And continue the course of steroid for 3 to 5 days. This is also important. And remember, tapering of dose is not necessary in case of acute asthma when you are using a steroid. You can give it for 3 days, or if you think that the patient needs more, you can give it for 5 days or even 7 days. There is no need of tapering. And if the patient is not on any controller, you should start the patient on daily inhaled corticosteroid. You remember, an episode of acute flare-up, a severe acute flare-up, is a very, very important indication for starting a controller. Another point is that whenever you get an acute flare-up, and if the patient is already on a daily inhaled corticosteroid, you have to consider stepping up the therapy for a short duration of 2 weeks or 4 weeks, and educate the patient regarding asthma action plan as well as the control therapy. Plan the follow-up visit within 2 days with their devices to demonstrate, and you always review the complaints and teach them regarding the trigger avoidance. So that is the important points. These are the important points we have to consider when discharging a patient after an acute flare-up. Now the last case, 10-year-old girl with asthma is brought to the casualty in an ambulance with oxygen by mask. On examination, she is sweating, she is very irritable, she is unable even to speak. On examination, her nails are dusky or blue, and on auscultation, breath sounds were not even audible. So what is this? So this is a case of life-threatening asthma. So this is a very, very important situation. This can come to our casualty, even in our peripheral setup. So what are the red flags which will tell you that this is a case of life-threatening asthma? So the important red flags are the patient who is having an acute episode of asthma, she is unable to talk or even cry. The chest movements are feeble, air is not even able to enter into the bronchus. The child is fatigued or exhausted. No breath sounds, or what we say as the silent chest, cyanosis. Any case of asthma with an oxygen saturation less than 92%, an irritable child or an agitated child, altered sensorium. So these are the red flags when we have to think of a life-threatening asthma. So such a case, when they are coming to your peripheral setup, what all things will you do? Most important thing, start oxygen, monitor SpO2. One important point is that you have auscultated and you're not hearing anything. Silent chest means the bronchoconstriction is that much severe is that air is not even entering the bronchus. So your inhaled SABA may not work in such a case. So the first step that you have to give in such a case is that you start the patient on adrenaline 0.01 mg per kg, just like a dose of that you are using in anaphylaxis. But here what is advised is that it should be given subcutaneous, not IM. Injection adrenaline 0.01 mg per kg. Terbutaline is not freely available, and that you have to give. And after giving that, you start the patient on inhaled SABA plus ipratropium, and you give the first dose of rescue steroid in the injection form and put an IV line also, and inform the ICU and arrange a proper transport. So one important point here is that whenever a child is coming to you with a life-threatening asthma, please do not directly refer the patient. You at least do these things. That is, you give an adrenaline, you start inhaled SABA, you give the first dose of steroid, then only refer. So make sure that you are treating the patient at least this much before you refer. Otherwise, if you refer a case of patient coming to you silent chest without giving anything, 100% the patient will die on the way. So always make sure that you are starting the treatment and then only referring a case of life-threatening asthma. So that is in short about the management of asthma in home, in OP, in ward, and in ICU. And these are some of the take-home messages. First and foremost thing, ensure that the diagnosis of asthma is correct. That is, what I meant to say is that you have to rule out the differential diagnosis, especially when the age of the child is less. When the child is less than 5 years, you should think of some alternative diagnosis also. Please do not always think that all cases coming to you with these is asthma. The second thing is that grade the severity, take a proper history, as well as using the vitals and the pulmonary index scoring, grade the severity and treat accordingly. And short-acting beta agonist, systemic steroids, and oxygen are the mainstay of acute management. In most of our cases that we see in the periphery, we will be able to manage with these three drugs alone. And finally, another important point is always give the patient a written asthma action plan. That is what they are expected to do when they get an attack at home. So these are the important take-home messages. So thank you so much for your patient listening. If you have any doubts, we can.
Thank you, sir. There are some questions in the chat box here.
I will stop sharing.
What is the preferred IV steroid in management?
Okay, so steroids that we can use are hydrocortisone, methylprednisolone, dexamethasone. All these things we can use. So the important point is that whichever steroid you are using, the efficacy is almost the same. There is no nothing like that. One steroid is better than the other. The only thing is that dexamethasone, you can give it for a short course. That means 3 days of oral prednisolone is almost equivalent to a single dose of dexamethasone. Dexamethasone, other thing is that it is long acting. So all the steroids are almost equal, and any of which you can use. Any of them you can use.
Okay, sir. One question is whether we decide the dose of MDA salbutamol based on weight.
Yeah, you can. When you are using an MDA with this thing, that I mean steroid or salbutamol, we have got charts based upon weight. You can start the let it be budesonide or whatever it may be. Charts are available both in GINA as well as our ABC consistency ATM, and based upon that you can use. And to start with, the dose is 100 micrograms. In majority of cases, budesonide we are using 100 mg BD is the standard dose.
Okay, sir. The next question is, as every child with asthma becomes better, should we start on inhaled intracortical steroids?
I didn't get the question.
If we are getting any child with acute asthma, should we always start on MDIs, on inhalers?
Yes, yes.
And
Yes, that is what I told. A case of acute flare-up, a severe acute flare-up is a very, very important indication to initiate the child on inhaled corticosteroid. Initiate the child on a preventer.
Even in mild also?
Yeah.
Mild cases
yes,
also.
Acute flare-up, let it be. So you should always remember that even a mild case of asthma has got a very great risk to become the mortality. That is what that was the reason why in the last GINA onwards, 2021 onwards, the standalone SABA as a preventer has been discontinued, and for all age groups more than 5 years, it is advised to use a steroid along whenever you are using SABA, you are advised to use a steroid. So even mild cases of asthma can become severe and can cause even mortality.
Okay, sir. One question is actually they want to know the dose of budesonide, sir, MDA dose.
Budesonide MDA, that is 100 mics BD, you can start, and depending upon the severity and weight, there are charts available, and you can use those charts to decide the dose.
Okay, sir.
100 mics BD is the starting dose. And if the patient is on 100 mics BD and the patient came with an acute flare-up, then you can, for a temporary period, for a short period of 2 to 4 weeks, you can upgrade the dose to 200 mics. Then tell the patient to, after 2 weeks, you come back to the original dose.
Okay, okay, sir. One more question is, I didn't get the question actually. If oxygen is not used for more than saturation of more than 92%, will there be ventilation mismatch?
No. What I meant, if oxygen is available, it is always preferable to use oxygen. So it is let it be a mild case or moderate or severe case, if oxygen is available, always try to use oxygen. I was telling that if 92% more than 92% in such a situation, if oxygen is not freely available, so if it is available, you should use.
Okay, sir.
Yes, that is right. What Anju said is right. If even in more than 92%, if we are using salbutamol nebulization alone, there is a chance that ventilation perfusion mismatch will occur.
Okay, thanks, sir. But usually in our PHSCs everywhere, we look at the saturation and give nebulization.
Yes,
And,
our PHCs, if oxygen is available, we use. Especially for small kids, we won't take risk.
yeah,
Small kids,
exactly.
we always prefer to use oxygen.
One more question, I think, sir, serious. He wants to know how we use, how many times daily we use both LABA as well as ICS.
That is usually given BD. Usually given BD. That is the advice dose.
Okay, sir. One more question, I think.
No, I don't. What he meant was about acute asthma or when it is used as a preventer.
No idea. No idea, sir. No idea, sir.
And if it is used nowadays, what we are using is the smart therapy. That is both as a preventer and reliever. You can use a single inhaler, a combination of formoterol and budesonide. That is what is called smart therapy. When you are using smart therapy as a reliever in acute asthma, what is recommended is that you can use a maximum of 6 inhalations per day.
Okay, sir. Then is the dose of salbutamol and levosalbutamol same?
No. Dose is different. Roughly, we can say levosalbutamol, the dose is almost half of salbutamol.
Role of montelukast and how long to use?
Montelukast has got no role in acute asthma. Only role is that as a preventer, it can be used, montelukast. And there also, compared with inhaled corticosteroid, its role is inferior. It's a second option only, not equivalent to inhaled corticosteroid.
Okay, I think.
And how long means there is no specified guidelines for that. But usually in our for our practical use, what we are doing is that we use it for 6 months.
Okay, is duolin respules contraindicated?
Duolin respules are not contraindicated. Duolin is a combination of this thing, SABA and ipratropia. You can use that. That is what I told when you are using a ipratropium along with salbutamol, either you can mix it or you can use it alternatively. Duolin is not contraindicated.
And just has asked how does ipratropium?
It is not contraindicated, but it should not be used in situations where it is not indicated. Means in a very mild case of asthma, SABA alone is only what is needed. There is no need to add ipratropium. Only if the patient is not responding to SABA alone, you add ipratropium. That is what is said.
Okay, sir. I think almost all the questions have been covered. I think almost all the questions have been covered, sir. Thank you, sir. Now coming to the vote of thanks. On behalf of our President Joseph Patani, sir, and Vice President Dali, madam, I thank our speaker, Krishna Mohan, sir. You really you gave a nice overview about, especially for the general practitioners, about how to approach a child when a child comes to, sir, one more question, sir. Advising home nebulization, how safe is it?
Home nebulization is not recommended at all. We are not recommending home nebulization. Even the latest ATM module also, as in the Indian scenario, we are not recommending home nebulization, because the one thing is that when we are giving nebulization at home, we may not be able to use oxygen along with that.
Yeah. Okay, fine. Thanks. I hope no more questions from chat box. And now I thank our Dr. Krishna Mohan, sir, for taking that elaborate session. And asthma, it's actually monsoon is coming and many kids will come to our OPDs as well as casualty with acute exacerbation as well as with first episode of asthma. And I hope all those who attended today's CME have got a very clear picture about how to deal each as mild, moderate as well as a severe case of asthma. And thanks, sir, for the excellent session. And thanks for taking extra effort and coming and joining our IAP Kottayam. And I would like to thank AGMI Kottayam for providing us this opportunity, and it's all its members for joining today the CMA, and I hope it was useful to all of them. Special thanks to Bennett sir, who joined and for coming to felicitate, as well as sitting throughout the session and clearing some of the doubts also. And I thank all IMA, IAP members, all the senior members and KGMA members for making this conference a success. Thank you.
I want to make
one point from my side.
Yes, sir. 1 minute, sir. 1 minute. About Bennett sir, I think Bennett sir has written one article in Malayalam in IMA Nammude Arogyam. It's a wonderful article, and I think it has got the Malayalam translation of this asthma action plan and all. So that's a very, very useful thing.
Thank you.
Okay. Thank you, sir.
Tomorrow, actually, this general practitioners empowerment, we have to make it in a large scale. And tomorrow, because the nowadays the investigation what we send, മലയാളത്തിൽ പറയാം, അതായിരിക്കും കൂടുതൽ എനിക്ക് എളുപ്പം. അതായത് നമ്മൾ സാധാരണ ഇതിൽ ഒരു ഐഡിയ കിട്ടിയില്ലെങ്കിൽ ഉടനെ തന്നെ ഇൻവെസ്റ്റിഗേഷൻ വിടുന്നു. ആ ഒരു കൺസെപ്റ്റൊക്കെ മാറേണ്ട സമയം കഴിഞ്ഞ്. അപ്പോൾ അതുകൊണ്ടാണ് നാളത്തെ ടോക്ക്, ട്രിവാൻഡ്രത്തിൻ്റെ ടോക്കിൽ വരുത്തിരിക്കുന്നത് നമ്മുടെ ചീഫ് കൺസൾട്ടൻ്റ് ആണ് ചെയറിങ്ങും, അവിടുത്തെ തന്നെ പെത്തോളജിസ്റ്റാണ് സ്പീക്കറുമായിട്ട് ഡോക്ടർ സ്മിത. ശരിക്കും പറഞ്ഞു കഴിഞ്ഞാൽ എല്ലാ മെമ്പേഴ്സും അത് അറ്റൻഡ് ചെയ്യുന്നത് നല്ലതായിരിക്കും. KGMA അനന്തപുരി CME സീരീസ് ആണ്, KGMA ആണ്, ബട്ട് IAP ഓൾസോ ഇൻവോൾവ്. നല്ലൊരു പ്രോഗ്രാം ആയിരിക്കും. കാരണം നമുക്ക് ഈ ഒത്തിരി ആവശ്യമില്ലാത്ത ഇൻവെസ്റ്റിഗേഷൻ വിടുന്നതിനെ അവോയ്ഡ് ചെയ്യാനായിട്ട്.
Okay. Sure, sir. Thank you, sir. Good night. Thank you. Thank you, Dr. Tony. Thank you.
Okay.